Okay, so what do they look like? So I guess a striking feature for me is when people just really have a really poor awareness into what's going on for them and the implications of the different symptoms that they might be having, or the implications for the different treatments that may or may not be available. And I guess mental inflexibility is, quite apparent when people get stuck on an idea, or they come and see you and they say, well, I want to try this and I want to do this, and people are given, appropriate feedback, and just even if they want to. And I've had a patient say to me, look, I understand, and I actually want to move on from what we're talking about, but I can't let it go. I just can't let it go. So sometimes even the person can be quite, distressed about the fact that they just have this really narrow focus on what they want. And despite, even accepting and saying, okay, well, you might be right, but I still want to do it this way. And, often they don't even know why they're not able to move on. If you're seeing, people that just can't wait and, are showing really demanding behaviour, so I want it now, I can't wait. It can be related to, I guess, a bit of a disinhibition or some, I guess, reduced social appropriateness. Is they want it now and they don't care what they have to do, they want it now. And so when you have people that used to not be demanding and are now quite demanding, that's, might be a bit of a flag to consider what else is going on. There might be a limited ability to put themselves in other people's shoes, and this is really, really devastating for families when people lose empathy, or social cognition as we're kind of calling it at the moment. So if you can't take, okay, things are difficult for you, but if you can't really see that your carer is really, really struggling and you want them, they have to have dinner, you want dinner at 6:05, that means your carer has to give up a day of work. So there's really that dissociation between knowing what's going on for other people and emotionally engaging with what's going on for other people. So people lose empathy or the ability to put themselves in someone else's shoes. And that can be really, really difficult. And it's often when people have these difficulties that reasoning often has limited effect. So it's almost that you have to be working and empowering the carers to really take control of the situation and setting up what they're able to do and what they're not able to do, and working from there. And I guess another thing that certainly strikes us at clinic as well is when people come in and they're talking about, that they've got this disease and they probably only have this long to live. But, they're kind of telling you in a really unconcerned way, or, might be having a little giggle as they're doing it, and, oh yeah, but then I can do this. And so there's, I guess a real lack of appropriate concern about the situation. And while that itself isn't enough to make you say, oh, well, this person's obviously got cognitive impairment, there's just these subtle red flags that you might need to keep an eye on to see whether that is still there, or maybe they were just having a bit of a bad day, or is there something psychological going on. But it's these things that you need to closely monitor over time, just to see. You might just think, well, that's a little bit off. I'll just keep that in the back of my mind and have a look at that next time that I see this person. Okay, and we've talked quite a bit about these behavioural issues, but just the importance of adynamia. It's often easier as a clinician, and I know that I don't get referrals for people that are adynamic. I don't get the referrals for the people that are sitting lovely and calmly on the ward in their chair watching TV, or staring at them, just watching the ceiling, because they're not causing trouble. They're not difficult. They're lovely. They're really easy to provide care to. But I think that we, underestimate the impact of this. And I think David made a really good point in saying, we need to keep encouraging people to engage in things. Really what we need to do with people that have adynamia is set them structured routines, find out what they might not be so interested now, but what really interested them and inspired them in the past, and really try to continue to get them to engage in activities, because if you don't, they will not do it. They will sit in their chair and they will watch TV, and life will pass them by and the disability will increase. So even though you might not get referrals, if you notice this in somebody, it is really important to address. And obviously disinhibition is what I get lots of referrals about. So these are the people that are having difficulties on the ward. Okay, so I'm just going to give you a quick overview. They're just some things up there that I guess what we can look out for as clinicians. So, asking about if people are having car accidents, any falls. We had a report recently of someone, a call from a nursing home when someone was accidentally running into people with their wheelchair. They're potential signs that something might be going on. And often poor carryover between therapy sessions, inability to follow through on recommendations, inconsistent reports of behaviour, and reports of changes in activity level. And I guess we've talked about why these things matter, and it really impacts day-to-day functioning and quality of life. And this is how cognitive and behaviour changes can make us feel if we don't address them. And I guess the other thing I wanted to finish up on too is it's uncomfortable for us to wait for people to give us the responses that we need. And what we need to do is hurry up and wait. Try 10 seconds, wait 10 seconds, and you'll feel very, very uncomfortable. But wait, and I've certainly tried this with my patients that I see, and they will provide you an answer. You just got to give them time. Okay, and we've talked about those. So I guess cognitive and behavioural symptoms impact in a complex and disabling manner, and you will get good days and bad days, and that is the norm. And just some, I guess, take-home points. Straightforward and simple therapy goals. Written information, structured routines for people with adynamia, and again, like David mentioned too, include families in interventions. If you don't include the family, the intervention will be less successful if you're trying to set it up in the home. Okay, and that's it for me. So hopefully people found that useful, and I guess, again, the more aware we are, the more we're able to see cognitive and behavioural changes, the better we're going to be able to provide care and support for our patients and families. They're just some references. Thank you.